Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month, I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness. In this episode of the NEI Podcast, we are talking to Dr. Roger McIntyre, and I'm so excited that we have the opportunity to do this today. This will be an extended Q&A session from our March NEI Synapse Half-Day on the cutting edge of mood disorders. In this episode, Dr. McIntyre will have a chance to answer many of your unanswered questions from the Q&A session that we had that half-day. Welcome, Dr. McIntyre.
Great to be with you, and I really love the format. Looking forward to our questions today.
Excellent. My first question for you is the risk of metabolic syndrome due to the use of second-generation antipsychotics?
It's a great question. We know that the metabolic syndrome prevalence in people with bipolar disorder approaches twice the rate of the general population. So quick mathematics, it's about 23 to 25% in the general population. It's about 50% in people with bipolar disorder. There is no doubt that there are aspects about this that are caused by medications like second-generation antipsychotics. At least some of them, not all of them, are particularly prone to weight gain. In addition, other medications in bipolar, which would include, but not be limited to divalproex or valproate, can also cause weight gain. And of course, there's many others. But I want to really press the point that it's not just weight from medications. It's also part of this is lifestyle. In other words, poor food choices, which is in part influenced by economics, sleep disruption, which is weight gain promoting, low levels of physical activity relative to the general population, as well as the biology of bipolar disorder, wherein we know that there's immune dysregulation or alterations in the stress response systems that are part of the biology that also contribute to metabolic syndrome. So there's a host of factors, behavioral factors, biological factors, social determinants, but also, yes, medications is one of those aspects.
So interesting. The next question that we have is, what is the age limit for the rapid screen tool?
That is a great question. The screening for bipolar disorder should take place in any person in adolescence or adulthood who presents with depressive symptoms. I really believe strongly that anyone with depressive symptoms or anxiety symptoms should be screened for bipolar disorder. Now, a screening tool makes our life easier. It's structured, it's simple, it's patient administered in our waiting room. It doesn't diagnose bipolar, but because of the robust negative predictive value, what that means is if they screen negative, they don't have bipolar disorder. If they screen positive, it does not mean they have bipolar, but it means we have a very strong suspicion. The rapid mood screener was validated in people over the age of 18, so would not be a screening tool for people under the age of 18. But I do think many of the questions that are in the rapid mood screener can guide the type of questions that you might ask an adolescent, for example, presenting with depressive symptoms.
What impact or changes have you seen in your bipolar patients who have suffered from COVID?
For me, the biggest, I guess you could say, impact that COVID has had on my patients with bipolar disorder is it has really exacerbated some of the social determinants of health. In other words, a lot of my patients have been living check to check. There's a lot of economic insecurity. There's housing insecurity and food insecurity. And that has been worsened by the situation. Many of my patients have lost their jobs. They've lost their homes. I've heard from patients about not, in fact, necessarily ever in their whole life going to a food bank, now going for the first time to a food bank. So I've definitely heard those narratives. Secondly, what I've also observed is that because people are going through so much distress, they're experiencing symptoms which are phenotypically a lot like depression. They're tired, they got brain fog, they lack motivation, there's a decrease in enjoyment. And they're calling me up saying, do you think my depression has come back? And the answer is, let's chat more. And the outcome is, yes, it has come back in some cases. We've reported in our research that people with bipolar are more at risk of decompensation during this time. But for everyone, it's not necessarily depression. Others it may be something else, related to feeling more lonely, a sense of isolation. In those types of situations, the outcome is I try to get them more engaged in community groups and community organizations with friends and family. So not all, they say in asthma, not everything that wheezes is asthma. Not everything that is feeling down is depressed. It certainly is our leading candidate, but sometimes it's not. So I've seen this kind of what I call phenocopy of depression. I've seen a lot of worsening of depression. And what I've really seen is an exacerbation of these social determinants of health, which are unfortunately overrepresented in our population.
So interesting. The next question is, how do you differentiate people with opioid use disorder from people with bipolar disorder? Probably many have both.
They really do. And it's a great question, Sabrina. What we know, and I recently reviewed this in an article that I published in The Lancet, is that people with bipolar have extraordinary rates of comorbidity. In fact, for those who love statistics and numbers and percentages, 90% of people with bipolar disorder have one or more other concurrent conditions. 50% have at least 3 or more other concurrent conditions, which I refer to as polymorbidity. So for those who are looking for life as simple, I don't think bipolar is life as simple. It's a very complex presentation with plenty of concurrent conditions. And substance use disorders broadly, and certainly opioid use disorders, are more common. We as clinicians are very often asked to disentangle this. Is the person's symptoms a consequence of the drug and alcohol misuse, in this case opioid use, or is it a comorbidity? Maybe in some cases they're using drugs because it represents their manic choices or bad choices. I think all the above is true. I think in some cases drug misuse predates bipolar. In other cases, it's the other way around. And I have patients, I'm sure many of my colleagues do as well, who only abuse drugs and alcohol when they're hypomanic or manic or mixed or depressed. In other words, when they're symptomatic. So the way I try to approach this, Sabrina, is really go back to the basics. In other words, what was the age and onset of their bipolar? How many episodes do they have? What are other comorbidities? What's the type of symptoms of depression that they have? What's the family history? In other words, am I able to convince myself that yes, along with consuming opioids, which can be deleterious to their health, mental and physical, is there a good case to be made that the symptoms exist in isolation or independent from opioid use? In other words, if they started having symptoms in their teenage years and 20s and did not use opioids until after that, that's one piece of evidence suggesting that this is a standalone diagnosis from opioid use disorder. So you're looking at what we call the temporality. Temporality just simply means what's the time-wise association between using drugs and having symptoms. If they haven't used drugs, let's say they were sober for 6 months or 9 months, but they continue to have all kinds of symptoms, that sounds to me like that's a separate condition. So it goes back to the basics. People say you can't diagnose bipolar in someone who's abusing drugs or alcohol. I would disagree. You certainly can. It's obviously more complicated, but you can by taking a really good history.
Wow. That's great.
Yeah.
What is the evidence that obesity leaves one vulnerable to bipolar disorder? Is this an association or is there any causal evidence?
Sabrina, this is a question that has really fascinated me for so long. I had trained conventional medical school and I had learned that obesity was because you ate too much and didn't exercise enough. We've really moved beyond that conceptualization. Obesity is a result of a disturbance in brain function. It involves aspects of cognitive control as well as reward-based decision-making. And a lot of people who are obese, not everybody, but a lot of people have a terrible problem with impulsivity of eating. And secondly, they're just agonized with cravings for food. And that's a problem with the reward circuitry. That's a brain problem. And so these individuals literally have a brain alteration that is leading to chaotic impulsive eating and often eating in excess of caloric requirement, things like that. But the evidence, Sabrina, tells us, which is really interesting, if you look at cross-sectional, but perhaps more enlighteningly longitudinal studies, it does appear as though obesity does predate the onset of bipolar in some cases, or said differently, more towards the question, yes, we do think that obesity increases the risk not only for major depression, but also bipolar disorder, but admittedly a higher risk association with major depression. Said the other way around, people who have bipolar disorder are more likely to gain weight over time, in part because of their lifestyle, their phenomenology. We talked about their medications that can also contribute, things like that. And for those who may be a little less familiar with this, there's an incredibly interesting story, because we know that other disorders that are characterized by impulsivity and reward-based decision-making abnormalities like ADHD in kids and adults is also associated with elevated rates of obesity unless they're treated, which is not, but if they're not treated, it's an elevated risk. And so we believe that obesity not only has effects on the brain, I call that the metastasis of obesity to the brain, but when the brain has these alterations in decisions, its decisional capacity, impulse control, reward-based decision-making, that predisposes obesity. So it goes in both directions, and there's probably some degree of pathogenetic overlap.
Wow. So interesting.
It's really interesting. It really interesting.
Yeah. This person says, I have had patients gain large amounts of weight on Vraylar, Abilify, and Latuda, approximately 40 to 80 pounds. Wow. What can we do with these patients with the exception of adding metformin? These are supposed to be weight neutral.
Yeah, absolutely. So look, it is what it is. These medications are generally almost weight neutral or weight neutral. And that's certainly an unfortunate scenario for that person affected. And clearly there's something about that individual. I would conjecture their genetics or something about their metabolism that's putting them in this rare situation of gaining that much weight, but it is what it is. By the way, just parenthetically, I wrote a paper a few years ago where I conjectured that obesity in bipolar disorder is not only increasing cognitive impairment in our patients, which it does, but it also results in a presentation that's more mixed. In other words, rather than it gets them more mixed. Rather than the elated, euphoric presentation, they tend to present with what I call the 4 A's: anxiety, agitation, anger, and attentional problems. And that mixed is more common in obesity. And that's probably goes back to what we talked about, Sabrina, a moment ago, the effect of obesity on brain structure and brain function. With respect to what I would do about that, yes, I've used metformin over the years, 500 milligrams to 2,000 milligrams as a primary prevention and as a secondary prevention. In other words, prophylactically and then secondarily if they've already gained weight. Admittedly, I've been a little underwhelmed with metformin. It's one of the options. Some patients do pretty good with it, but I've been a little underwhelmed overall. A little too many unders and overs there. But when it comes to what I use a lot of incretins. So drugs like liraglutide, semaglutide, these are drugs that are FDA approved for both diabetes type 2 as well as obesity, in some cases, not always. And these drugs I will use off-label or on-label in some cases, but off-label in most cases. The incretins, not only do they lose weight in ways that are extraordinary, but they also, in fact, have some beneficial effects on the brain. We've done some work at my lab showing that liraglutide, for example, can improve cognition and reward measures in people with bipolar. I've also used in some of my patients the combination of bupropion and naltrexone, which is known as Contrave. I've done that in some patients with bipolar to good effect who've had weight gain from the illness and or their medications. A bit more complicated because buproprion's an antidepressant, and that could be a bit of a problem for some of our patients with bipolar disorder. Notwithstanding, I have found it to be the case that for me, the incretins work quite well. My fingers are crossed, Sabrina, a little later on this year. We're hoping, don't know for sure, but we're hoping the FDA will approve a new version of olanzapine that has samidorphan woven into it. It's a combo pill.
Right.
And this is really interesting because we know that opioid ergic modulation can result in a decrease in weight. And it's been shown that when you add samidorphan to olanzapine, it does attenuate the weight gain liability of olanzapine. Right. And that would be pretty interesting, I think, for some patients possibly.
That's exciting.
Yeah, it really is. It really is. Because olanzapine is one of those types of drugs that we all know it works really well and it's easy to use, but the weight gain was always a deal breaker understandably for people, and there's metabolic consequences as well. But with samidorphan, it does attenuate the weight gain liability. Of course, we welcome that.
This person asks, what was the web address for the bipolar depression study information? We can add that into the show notes.
Oh, great. Yeah. One of the frustrations I've had, I'm sure I'm not alone, is when someone has a screening tool, I can never know where to find it or where to get it. So what we did was when we published the Rapid Mood Screener, the RMS, Rapid Mood Screener, we said, heck, let's make this freely available. No cost, no fee, no charges, no royalties like that. Make it free. And most of my colleagues don't have subscriptions to medical journals. So what we did was we published it in a journal, which we want to do to have it peer reviewed, and which I think is important. But we want to make it free of charge. So it's what's called open access. So people can just download it free of charge. The easy way, and again, we can probably put this in the notes, Sabrina, is folks can go on PubMed. Everyone knows PubMed, and just type in Rapid Mood Screener, and you just type in my last name, McIntyre, and it should be optimized. And you just click, and you'll get the article as well as the actual screener. Maybe we can leave some of that in the notes.
Excellent. Sounds good. The next question is, how about the combination of quetiapine, I'm not sure if I said that right,
yeah,
and lamotrigine as a combination for acute bipolar depression?
It's a great question. I've done it very often where I've combined drugs like quetiapine with lamotrigine. And what's interesting about that question is that quetiapine is only one of two drugs that's been really sufficiently studied in bipolar II disorder. You see, when quetiapine got the indication of bipolar depression, it included bipolar I and bipolar II. Most other medicines only studied bipolar I. Now, lumateperone is not yet FDA approved for depression. We hope it will be a little later on this year. And what's really interesting is that lumateperone was studied and shown to be effective in bipolar I and bipolar II depression. So I bring that up, A, that's interesting, I think, and relevant, but B, I find lamotrigine very helpful for bipolar depression. It's an off-label use, and I find it especially safe and easy to use and very well tolerated. The rash is not a problem in most cases. We start low, go slow, especially in bipolar II. I see a lot of university students, young adults, and they want something obviously very well tolerated. I see a lot of BP2, and I not infrequently have the combination of lamotrigine and quetiapine. That being said, I would say that I have had bad luck with quetiapine when it comes to the sedation, the sleepiness, the weight gain, the metabolic disruption. It still remains an option. It's on the radar screen. I do consider it, but clearly that has been a problem, those side effects I talked about. And so I have gotten into the habit of combining lamotrigine with lurasidone, I call double L therapy, or lamotrigine with cariprazine. And I can tell you, it's not going to be too long until we start combining lamotrigine with the other L, lumateperone. That's off-label right now, but it may get an indication this year of bipolar. It's a very interesting question. We do have other options that are less likely to cause sedation and metabolic problems.
Excellent. Is it better to start out with a mood stabilizer or antipsychotic, and why? And then the next question, is it possible to treat bipolar disorders with just one class of drug, or does it always require the combination of mood stabilizer and antipsychotic? Those two questions went together.
Yeah, absolutely. And they naturally do go together. Those are great questions. A couple of maybe almost background comments first before specifics. When we look at the state of the union in medicine, not just in psychiatry, but medicine broadly, there's a survey that comes out annually called the National Ambulatory Medical Care Survey that looks at pharmacology prescribing, and this is all pharmacology, not psychiatry only, across America. Interestingly enough, bipolar disorder comes up on the top 10 list with respect to the medical diagnosis receiving polypharmacy. In other words, more likely to receive polypharmacy. And this has been looked at in many of our research studies, and what reads out is that the modal patient, in other words, the most commonly encountered patient with bipolar disorder, has between 3 and 5 medications. So polypharmacy is the rule rather than the exception. Notwithstanding that being the rule rather than the exception, it's certainly not our objective to put people on so many medications. It's our objective to have them on as few as medications as possible. And I have, and I'm sure many of my colleagues do, patients in their practice who've done well on one drug for many years, like lithium. I've had many patients been with lithium for 20 years, 30 years, 40 years, long before I even some people I was even born. They've been doing well on lithium monotherapy. But unfortunately, that's a rare situation. So we go into this with a aim for monotherapy. We end up having to add medications together. I've tried to avoid now using the language mood stabilizer because I think mood stabilizer has become a fuzzy concept. It used to mean lithium, Depakote, or divalproex, or carbamazepine. But now we have second-generation antipsychotics, many of which have shown and have FDA approvals across different phases of bipolar, including long-term recurrence prevention. So they are mood stabilizing. So for me, what I find more helpful as a way to categorize bipolar medicines, are they anti-manic? Are they antidepressant? Do they have recurrence prevention effects? And that's probably a more coherent way for me to do it. All of the atypicals, just about, with one exception, have anti-manic efficacy. Only a handful have antidepressant efficacy. That certainly doesn't exist for divalproex, and lithium's got less antidepressant than anti-manic efficacy. And then for recurrence prevention, we have certainly long-acting injectables like aripiprazole. We've got lamotrigine, other atypicals like quetiapine. But here's the zinger, Sabrina. Depakote or divalproex is always called the mood stabilizer, but it's never been shown to be a mood stabilizer in the conventional way we defined it. It's been shown to be an anti-manic, but not an antidepressant, and it doesn't have recurrence prevention data in the long term. That's why I think we need to orient ourselves a little differently, how we think about these medicines. And yes, I very often would combine different classes of medications together.
Wow. This next question is, what are your thoughts and experience regarding MAO inhibitors for bipolar depression 2 with atypical features?
What a beautiful question. The monoamine oxidase inhibitors have almost become forgotten about, and that's really a shame. I think it's a bit like forgetting about penicillin. These are old drugs. We've had them dating back to the serendipitous observation that iproniazid, which is a derivative of isoniazid, could improve mood symptoms in TB asylums, tuberculosis asylums. That was the first monoamine oxidase inhibitor. I still use monoamine oxidase inhibitors to treat bipolar depression. I absolutely do. I'm often asked what's some of my favorite antidepressants, and in the top 3 list, you got it, monoamine oxidase inhibitors. I think they're underutilized. There's no doubt about it. There's safety and tolerability concerns. But I think, frankly, Sabrina, the safety concerns have almost hijacked the appreciation of the efficacy. We don't want patients to have elevated blood pressure, et cetera. Of course not. But there's many ways around that. And there's a diet called the Sunnybrook diet. People can download that, which provides a bit more kind of latitude on the types of foods you can eat and take MAO inhibitors. Back in the old days, we'd say no cheese, no wine, you can't use this, don't do this. Basically, you got to live a life of almost like a monk living in a monastery. Who wants to live like that? And my patients would say, I can't live like that. And so there's now more latitude on the diet, and pharmacists are very skilled on giving you a readout of drug interactions. But to be perfectly frank, I don't find, this is going to surprise some colleagues, I've used MAOs literally in the thousands of times. I don't find them that difficult to use, and I find them generally quite well tolerated, and they work really well. And the question around atypical symptoms is really interesting because there's a literature to show that people with bipolar depression have more atypical symptoms, which simply means more hyperphagia, they eat more, hypersomnia, they sleep more. And they have this real terrible psychomotor retardation, which we call leaden paralysis. And MAOs are just a fastball down the center of the plate for those symptoms. It just treats them head on. And I have found, yeah, absolutely. Now, I don't want to overstate it. I wouldn't give MAO inhibitors as a first-line treatment. I'm not implying that. There are concerns with antidepressants in bipolar. I typically would add them to an anticonvulsant or lithium or a second-generation atypical. I don't use them as monotherapy is what I'm getting at. But I do think that they are underutilized. And for people who work with very tertiary more difficult to treat depressions and bipolar, they've got to be in your toolkit.
Do you have suggestions for treating comorbid generalized anxiety disorder or panic disorder with bipolar depression that is non-responsive to second-generation antipsychotics?
Oh, that's really great. And it stole my first line thunder with respect to second generation. This is a great point because it led to a multiple choice question I created for our residents in psychiatry quite a few years back, where I asked them, what's the most common type of mental disorders, comorbid and bipolar? And they all circled drug and alcohol. That was the wrong answer. It's actually anxiety disorders are the most common comorbidity in bipolar, social, generalized, and panic anxiety. So this is common. And for those who like statistics and percentages, it's between 50 to 75% have some type of anxiety, social, generalized, or panic. And there's a neurobiological overlap between bipolar disorder and anxiety disorders. And no wonder there's a treatment overlap. Yes, absolutely atypicals. I think you want to optimize atypicals for bipolar. Each of the atypicals that have shown efficacy across phases of bipolar have also shown the ability to attenuate anxiety. So that's a very good tactic clinically to consider. What we know from the literature is that people often give antidepressants to treat anxiety and bipolar. I don't do that. I'm just saying I recognize that's done. I don't do it. The evidence is not there. And there's hazards with the antidepressants. They could be destabilizing. If, in fact, the optimization of the atypical doesn't deliver sufficiently, what I use is either gabapentin or pregabalin. Again, this is all off-label. And these GABAergic drugs, in the case of pregabalin especially, have been really studied in GAD and panic anxiety and social anxiety and shown to be safe and effective. In gabapentin doses, they range between, say, 600 and 3,600 milligrams. Pregabalin, it ranges between 100 and 500. Most of my patients are between 100 and 300 milligrams a day. And I find, frankly, they work very well. I haven't had problems with abuse liability with those types of drugs, which is sometimes brought up as a concern. Benzos, we kind of tread with caution pharmacologically, especially in the bipolar population. Cognitive impairment, they can worsen anhedonia. And of course, we're always concerned about abuse liability. I wouldn't say that they're off the list in carefully selected patients. I do use them in some patients, but they're not my priority drugs in that case. And then finally, I might use a low dose of divalproex. Not my favorite because of the teratogenicity, the side effects, the monitoring. It's a drug that has a lot of side effects and monitoring burden. That being said, it can sometimes help the anxiety. My treatment of choice, frankly, Sabrina, is to, where applicable, where the patient's motivated, to get them into cognitive behavioral therapy. And now because of COVID, there's much more openness to online. In online guided CBT works just as well as seeing a patient, therapist in person. And maybe they can go on one of the online CBT programs. And sometimes it's relaxation techniques, behavioral techniques, cognitive techniques. And it's scalable. It's cost sensitive. It's very cost friendly, and it works.
Yeah, that's great.
But on that note, I'm just thinking because I when I was thinking about the question that was asked, I know my patients, what they do. They drink a lot of alcohol and they smoke a lot of cannabis to take the edge off their anxiety. And I don't agree with that. I don't think that's the right way to do it. We got to make sure patients hear accurate information that cannabis is not the right way to treat their anxiety, which is a very common thing going on out there.
And that's interesting that you said the first comorbidity people associate with bipolar is substance use or abuse. And it's interesting to think that maybe that's what they're using to self-medicate for what's really underlying that, which is more highly comorbid, which is the anxiety. So
that's right.
A really interesting point there.
Yeah, it really is. And you know what's interesting about that too, Sabrina, is that I've been guilty of this. I've really tried to press the point that in all depressed patients, we got to be thinking about bipolar disorder. And depression often is what precedes bipolar mania, but so does anxiety. And for a lot of patients, generalized and social and panic anxiety, they're not just comorbidities, but they're often what the patient was primarily bothered by through their adolescence, early adulthood, before, in quotes, bipolar, end of quotes, started to show itself. Very common.
Yeah, that's so interesting. The next question is, how Can one differentiate between unipolar and bipolar depression in clinic when we have time constraints in the clinic?
Oh, absolutely. I think time constraints on a good day, time poor is probably more the reality. We're all running behind schedule and it's not easy. I think you want high yield, you need high yield, highly economical questions. And you can't, in an ideal world, we'd be there for an hour and a half, 2 hours with every patient. That's not the world most of us live in. So I think having a screening tool helps. A screening tool helps because if the patient screens negative, I am not saying forget bipolar. I'm not saying that. What I'm saying is you've got a high level of confidence they don't have bipolar disorder. So that can help shape how many questions you're going to allocate to the interview on bipolar. If they screen positive for bipolar, it doesn't mean they have it, but it means you're going to just expand a bit more your queries around bipolarity. So already that can save you time. Just do a screening tool. They screen positive. I'll get into a bit more. And I ask them the key questions. Here they come. There's about a half a dozen, but they're really easy. It takes all of about a minute. When did your illness begin? How many episodes have you had? Do you have a family history of mental illness? What's been your response to antidepressants? And also, has antidepressants ever made you hypomanic or manic? Those questions take about 60 seconds, and those questions will take you from an uncertainty to a high level of certainty one way or the other. Very high yield questions.
Wow. The next question is, I've learned that the combination of lamotrigine and lithium is effective for bipolar depression. What is your experience?
Extremely positive, and I agree completely. I call that also, I mentioned double L therapy. I often just have a bit of banter with my patients when they say to me, oh, I put on everything for bipolar depression, nothing helps me. And I often, it's their dichotomous negativistic thinking talking there. And I say, have you been on the L's or the triple L's? They say, what's that? And I say, lithium, lamotrigine, lurasidone, and maybe another L later on, lumateperone, and lots of L's in the bipolar depression area. And the point I'm getting at is just remember the L's. And I have had great success combining lamotrigine with lithium. It's a safe combination. It's well tolerated. There's no meaningful drug interactions. Let's start off with that. First job in psychopharmacology, Sabrina, as you know, is don't harm the patient. So let's start off with that. And then the second objective is to try and help the patient. And so, and it turns out that lithium, it's interesting. I'm a big fan of lithium. And lithium has been clearly shown to be anti-manic. It's shown to be antidepressant and mood stabilizing, but its therapeutic octane, the therapeutic punch, is greater in treating mania than it is in treating depression. It doesn't quite do it for a lot of my patients. And that's not to be confused with something else. And that is that lithium is the only drug in bipolar shown to lower suicide. That's something separate, which is interesting. That's a good point.
Absolutely.
And so what I'll do a lot of the time, I'll have a patient, I optimize them on lamotrigine, say between 150 to 300 milligrams a day. If they're still symptomatic with depression, I can introduce lithium. And I don't feel like I'm held ransom always to go to a dosing to achieve 0.6 to 0.8 milliequivalent per liter. That's a reference range, but I've got a lot of folks on lamotrigine, 150 to 300 in that range, but they're on a dosing of lithium that's got a blood level around 0.4, 0.5, 0.6, and they are doing very well. And at that lower blood level, lithium is a lot better tolerated. And they can just take it once a day, reduces the polyuria that we sometimes see with lithium. So I find that combination is a really nice combination. And there's research evidence published that combination, which we call LAMLIT, lamotrigine lithium, is a very well tolerated, safe, and effective combo.
That's interesting. That's great. The next question is, how would you decide whether to begin cariprazine or lurasidone in treating bipolar depression?
It's a great question, and I'm going to probably expand it to even add more complexity to my my challenge here is when lumateperone gets approved, because it's going to be approved, we expect in bipolar depression as well. I think obviously there's going to be some factors that go beyond the medicine in terms of what's available, what do they have on their formulary, what they can afford. Obviously, patient preference matters a lot. And what they had previously, if they had Latuda before or Vraylar before and it worked, I'm probably going to go back to that. But in a patient who's naive to these medications, in other words, who's never had these medications, it's going to be based on a variety of factors. Cariprazine does have indication in mania and mixed, as well as depression, and that needs to be considered, especially patients who have a propensity to both mania and depression. Some might be saying, don't all bipolar patients have that propensity? Yes, but most people with bipolar disorder have a predominantly depression polarity illness. Some have more manic polarity predominance. In that case, I might gravitate towards a Vraylar if mania is more often complicating the picture. But I think within bipolar depression, I think at this point, we don't really have an evidence base to say Latuda versus cariprazine. They both have similar profiles of efficacy in depression and both have obviously a profile metabolically that's very friendly. So I think it's going to come down to a case-by-case basis, taking into consideration some of these other factors that I described.
Wow. The next question is, many patients have high levels of irritability and mood shifts hour to hour. They often have bipolar disorder, but they might also have significant trauma, and which would seem more consistent with complex post-traumatic stress disorder. How do we factor in PTSD symptoms when treating mood disorders?
It's amazing, Sabrina, from the questions. These are obviously my colleagues see a lot of patients, and this is a very common situation. We've looked at this. We've reported on this, the rates of ACE, adverse childhood experiences, in people who have bipolar. It's quite significant, whether it's abuse, whether it's physical, sexual, whether it's neglect, whether it's emotional abuse. These are common. And by the way, on a parenthetical note, we know that the age at onset for bipolar disorder in America is about 10 years earlier than it is in Europe. That itself is like mind-blowing. And what's thought to be the reason in part is the higher rate of trauma in people with bipolar in the United States relative to their Europe.
Wow.
Yeah, because trauma has been shown in bipolar to result in an earlier age at onset of the illness, a much more complicated bipolar, more rapid cycling, more mixed, more comorbidity. And it's a great question. Yeah, it's a really common situation in our patients. And then the phenomenology of trauma, wherein people have emotional dysregulation, they often have affective symptoms. These individuals have a lot of anxiety. They often have cognitive problems. This phenomenology is almost impossible to disambiguate from bipolar symptoms, which look almost the same.
Right.
And so what I find for myself, how I approach this is I try to approach this with mood charting, and I try to conceptualize. It's impossible to know with the utmost certainty. I try to conceptualize to what degree is the arousal, the affect dysregulation, the cognitive impulsivity, to what degree is that episodic? To what degree does that map onto hypomania, mania, or depression? Versus to what degree is that more a trait of the individual as a consequence of the trauma? And what I've noticed is what's been reported is that many of the drugs that we use to treat bipolar disorder, no surprise, they offer symptomatic relief for some of this complex PTSD phenomenology, cognitive impulsivity, affect dysregulation, sleep disturbance, arousal, and anxiety. So in some ways, the pharmacotherapy of bipolar kind of also pinch hits for the PTSD symptoms as well. Not always, but in many cases. A lot of these patients will require, in fact, most of them will require, I think, cognitive therapy or some type of maybe mindfulness-based therapy or some trauma-focused therapy, individual, group, in-person, or digital, that can synergize the pharmacology. So in addition to the pharmacology, the psychotherapy can provide for them additional tactics to help them organize their thinking, their emotions, and their behaviors.
Wow. Yeah. So this next question is focused more on hormones. And it says, please comment on the menopause transition and bipolar disorder and hormone replacement therapy and the risk of misdiagnosing major depressive disorder with PMDD or premenstrual dysphoric disorder.
Yeah, absolutely. Absolutely. You know, what's interesting, Sabrina, is that when we look at some of the times in a woman's life where she is at risk of declaring not just mental illness, but we're focusing on bipolar today, it's around what we call reproductive life events. So the onset of menarche, pregnancy, postpartum, and the menopausal transition. So on the menopausal transition point, there are two observations. Women who already have pre-established bipolar disorder are at an increased risk of decompensation during the menopausal transition. Moreover, women who have not yet declared bipolar disorder are at risk of first declaring it around the time of menopausal transition. Admittedly, that's not that common, but it could happen. It could happen. It's not that common, but it could happen.
Okay.
Yeah, it's really interesting. But pregnancy and postpartum is where you tend to see this declaration or recurrence take place more often than menopausal transition. I always tell people, any woman who is pregnant and depressed, and certainly postpartum depressed, you got to really make sure you're convinced they don't have bipolar disorder, because that's much more common to manifest during that time. When it comes to what's going on there, we're still, frankly, more in the dark than we are in the light with respect to pathogenesis is here. The obvious consideration is that there's sex steroid alterations. There's been an interesting story recently that progesterone, we know progesterone levels drop off, for example, postpartum. And that observation has led to the development of neuroactive steroids like brexanolone as a treatment for postpartum depression, which is very interesting, built on the story that progesterone levels, which act as, in many ways, neurosteroids, drop off in the postpartum period. So the pathogenesis is not fully sussed out, but what we do know has led to a very interesting FDA-approved treatment for postpartum depression. I think that the guiding principles going to the menopausal transition again are not a lot different than what we have with managing bipolar at any time in a woman's life. The question around hormone replacement therapy is extremely interesting. We did a study a number of years ago where we found that many of my colleagues might remember there was a scare about 15, 20 years ago. The Women's Health Study reported that hormone therapy led to an increase in health complications for women, and women stopped using hormone therapy for quite some time. And that led to a rise in depression and a rise in the prescription of antidepressants in one of our studies. And we reported on that. There's no doubt about it that hormone replacement, like hormone itself, like estradiol, or even some of these SERMs, raloxifene, which is a selective estrogen receptor modulator, these drugs are antidepressant. They actually are brain trophic. They communicate with dopamine. But we just haven't studied it sufficiently in bipolar depression. It's more studied in major depression, where we have hormone therapies showing antidepressant effects more so than in bipolar disorder. But it's a great question. It truly is. Sabrina, just on a separate note, I've been interested in a long time, and we see a lot of patients with premenstrual dysphoric disorder, which was part of the question. PMDD, we don't really know the underlying pathogenesis. We use often antidepressants to treat that. Sometimes we'll use oral contraceptives to treat that. If they have a mood disorder, they definitely need an antidepressant. And we tend to use antidepressants throughout the month, not just for 14 days before the menses. But what's interesting is that there is, in fact, a story unfolding that the majority of women with PMDD go on to have MDD anyways. That's why we give antidepressants throughout the month and not delimit it just to the 2-week premenstrual time. So a couple of points there, a lot to cover there. That's a big topic. But I think the key thing is let's be vigilant for bipolarity right along the reproductive life events.
Absolutely. The next question is basically just says, do you have thoughts on pramipexole for unipolar or bipolar depression?
I do, and I've used it quite extensively, and I still do. Pramipexole, among other things, is a D2, D3, a lot of D3 agonist. It's a dopamine agent. Many of my colleagues know it, would use it for restless legs or in some cases other conditions. I've seen it used in Parkinson's and things like that. Probably better known in restless legs. But I've used 1 to 3, 1 to 5 milligrams of pramipexole in combination off-label with antidepressants in people who just have not had sufficient improvement. They're having a non-remission. They have residual symptoms. And impressionistically, I have found pramipexole to be quite useful at treating fatigue, apathy, anhedonia. These are very common symptoms that are residual in patients taking antidepressants. Knock on wood, I haven't had any problems with new onset compulsive behaviors or impulsive behaviors. That was a bit of a concern with some of the dopamine agonists that you could iatrogenically or you could create in some compulsive, impulsive behaviors in some patients. I haven't seen that, frankly, with pramipexole. But something I'm aware of is people often bring that up to me. So I have, and I find it very well tolerated, and I think it does work. And there are randomized controlled trials where it beats placebo when treating depression in that type of paradigm.
Mm-hmm. The next question is, how would you treat pediatric insomnia in newly diagnosed bipolar disorder or mixed features while titrating Latuda or a mood stabilizer?
Well, I like the way it ended because I think that the way we want to treat the sleep disturbance, which, by the way, is job number one, you got to get people sleeping. It's an important part. If people aren't sleeping, their bipolar will not settle. And so I think we want to optimize the agent. I'm glad to hear lurasidone was mentioned. It has an FDA indication for the 10 to 17-year-old with bipolar depression and as monotherapy. And it does have beneficial effects on, among other items, the insomnia item in that patient population. If, in fact, that's not sufficient, of course, let's make sure we got good sleep hygiene. The kid's not on their cell phone at 2 a.m. and on TikTok and all this kind of stuff, smoking cigarettes and playing music at 2 a.m. That's typically not good for your sleep. So all that put aside for a moment, there are, in fact, now evidence for cognitive behavioral therapy insomnia. A lot of the kids are really savvy, of course, with apps. And there's some really nice app-based technology where they can learn about CBT for insomnia. That's very easy to find on the internet nowadays, especially with COVID. So that's something the kids quite like to do, and it works. Pharmacologically, and again, this is off-label, I do think getting kids to anyone with bipolar to sleep is a therapeutic objective priority. And if the psychosocial's not working, along with the fact that the kid is using good sleep hygiene, there's optimization of their underlying mood stabilizing regimen, then I think you're going to use judicious use of something else. And I would use off-label a low dose of maybe a trazodone, for example. I've had some success in some cases with a low dose of melatonin in some cases in these kids, and that usually does the trick.
This next question is, due to the high cost of Symbiox, do you see any problems with prescribing fluoxetine and olanzapine as two separate prescriptions together in the same patient, if abiding by the dose strength ratios?
Yeah, absolutely. As a guiding principle, you hear a lot of guiding principles. I've learned that in psychiatry, there's a lot of exceptions to rules. That's why I just live by guiding principles. I try, to the extent that I can, I try to use what has been branded and what's been created in its proprietary formulation. And the reason I do it is because I think details matter. And I've learned, and the evidence shows, that small differences in formulations, when there's like multi-formulations in one, can make a difference pharmacokinetically, pharmacodynamically, and maybe therapeutically. For example, bupropion naltrexone is a weight loss drug. Many people might combine those two together, but I just stick to what's been approved. And that would be the way I'd prefer to use Symbiox. Now, a drug's not going to work if the patient ain't going to take it. They can't afford it, so they ain't taking it. I long vacated the perfect world, and I want to go back to the perfect world. If anyone shows me where that is, please give me directions. I'm in the non-perfect world, and so I will do whatever I can. If they say, look, doc, I cannot afford this, I ain't picking it up. Okay, I can do one of two things. I can be rigid or I can be adaptive, and I'm just going to say I'm going to choose the latter. So I would consider olanzapine with fluoxetine and make it in my own garage, so to speak, for the patient. Absolutely, I would. That's not my preferred option. But I will finish, though. I used to love olanzapine on efficacy in bipolar. I don't love the side effects. They're brutal. They're bad. The weight gain, diabetes. So olanzapine has really been a non-starter for me for quite some time. That being said, we'll look forward to seeing olanzapine samidorphan. I think what we're going to see with olanzapine samidorphan, you're not going to see the total curing of all weight gain liability with olanzapine, but you're going to see sufficient mitigation of weight gain in some patients with this drug that would make it a starter in some patients rather than a non-starter.
Excellent. The next question is, do you find oxcarbazepine and topiramate useful in bipolar disorder management? And then what about carbamazepine? It seems as if it's not used as much.
Yeah, this is where the details matter, and I think that's true. Carbamazepine is not used as much. Last August, there was a report in the American Journal of Psychiatry looking at anticonvulsants in bipolar disorder during the last 2 decades, and you're right, carbamazepine has dropped right off, so that's absolutely true. If you come to my clinic and you pulled, say, 100 charts and just did a chart review, what you would find is that carbamazepine is still a reasonably popular drug at my center. Now, just to put it in context, I work at a tertiary university hospital. I see very late stage, very treatment resistant situations in bipolar. I don't use carbamazepine first or second or third line. It's something I use later because of the tolerability, drug interactions, and safety profile. But it is still a very good drug for treating mixed, especially very malignant mixed presentations, as well as treating my forensic population has a lot of aggression, or not even forensic, but just people with bipolar who have terrible aggression problems and impulse control around aggression. It's quite good there. So I still use it. I've been frankly disappointed with oxcarbazepine. I'm not sure why it doesn't deliver. It didn't quite deliver in the pediatrics the way we had hoped. I've had some patients benefit, but it does not seem to be the same thing as carbamazepine. It's a congener. It's related to carbamazepine, but it's different enough that it just doesn't seem to work in my hands. And the literature on oxcarbazepine has not been as robust as it is for carbamazepine. Topiramate, I've done studies with topiramate, and the Johnson & Johnson, who had the proprietary topiramate, studied it. And it just hasn't panned out. It did not work in bipolar mania. It did not work in depression. So I don't use it to treat bipolar, but I do use Topmax or topiramate to treat other manifestations that are commonly encountered in bipolar. Migraine, binge eating. Sometimes it can help me for weight loss because it causes weight loss, but it does have cognitive impairment as one of its side effects. And some patients do report when they take topiramate that their cravings for drugs and alcohol goes down. So I've used it for binge eating, drugs and alcohol, migraine, pain in some cases, and of course, weight loss if they can tolerate it.
That's excellent. This takes me to our final question, which is, which of your bipolar disorder patients would you refer for transcranial magnetic stimulation, and what has been the outcome in your experience? Have you seen any development of mania with this treatment because it is brain stimulation?
Exactly. TMS is part of a larger suite of neurostimulatory approaches. Of course, ECT, electroconvulsive therapy, being the granddaddy of them all. It still remains the most effective treatment in neurostimulation. In fact, one of the most effective treatments in all of medicine. And is the most effective treatment in treatment-resistant bipolar depression or major depression. But TMS is more acceptable and it's easier to take. And there are evidence that TMS does help patients who have bipolar depression. Where I see it in the algorithm is a bit similar to how we put it in the Florida Medicaid guidelines. And for those who are wondering, you can go to medicaidmentalhealth.org, where the Florida Medicaid guidelines have been positioned. They're circa 2020, updated just last year. And TMS is in there. It's on really down the list. It's on the 4th line. But rather than get into the detail and granularity of that, people can go to that resource. But what I would say is I would start with FDA-approved pharmacotherapy like lurasidone, cariprazine. We look forward to lumateperone very soon. I might consider a lithium or lamotrigine next. If that doesn't work, I'm asking myself, okay, what's next? What's next is not a whole lot to really be happy about because antidepressants have not been FDA approved and they don't have a robust evidence base. So I have the discussion with my patient about TMS at that point after 2 or 3 failures. I also have that discussion about ECT and about ketamine. We've shown that ketamine can be helpful in bipolar depression, and the risk for mania, psychosis, and dissociation is no different than major depression. So I think it is helpful for some patients. It's not as effective as ECT, but TMS certainly does better in public relations, if you will, versus ECT. And I do think that conversation takes place after you have exhausted the consideration of the FDA-approved agents for bipolar depression first, as well as lithium and lamotrigine.
That's excellent. Well, thank you so much for all of this great information. I think we addressed more questions than we ever have in a podcast episode. So hopefully a lot of people had their questions answered. And thank you so much for all of that.
Oh, a pleasure. Thanks for hosting me. Thanks to my colleagues for all your questions. Thank you so much.
This episode was brought to you by NEI Membership. The 2021 NEI Synapse Virtual Half-Day Series is included with NEI Membership. Become a member today so that you can register for free for any or all of the monthly half-days, in which Dr. Stahl and colleagues will spend the last Saturday morning of each month sharing cutting-edge research and clinical insights on the topics most relevant to real-world practice. Don't miss out. Become a member today. Visit www.neiglobal.com to learn more.